Hello, it's great to see such a wonderful turnout. So the Penn's ALS Center is at the same place that Dr. Rachel just talked to you about. It's at Pennsylvania Hospital. And we are an ALSA center, meaning we are partnering with the ALS Association. And just like there's a multidisciplinary movement disorder group, there's also a multidisciplinary ALS group at Pennsylvania Hospital, which includes neurologists like myself, but also Penn nurses, nurses from the ALS Association, mental health nurses, social service, PT, OT, speech, nutrition, adaptive equipment therapists, genetics counselors, lung physician as well, in order to take care of these complicated patients. And I'm going to talk to you today about ALS, which has a number of synonyms. Amyotrophic Lateral Sclerosis, I'll explain how that name got formed, also known as motor neuron disease, and colloquially in the United States, also known as Lou Gehrig's disease. And basically, this is a disorder of the voluntary motor system. So any muscle that you can voluntarily control can be affected by this disease, with some exceptions. And this is a cartoon of the voluntary motor system, and basically every voluntary muscle in your body is controlled by a group of cells in the brain, residing in the frontal lobe of the brain, right there. And these cells are quite large, and they have a large wire or axon that travels down through the brain and through the spinal cord, and they chemically contact another cell that lives either in the lower part of the brain, and those cells control muscles of the head and neck, or live in the spinal cord, and those cells control the muscles of the arms, the trunk, the legs. These lower cells, in turn, are quite large and have a wire that comes out of them that goes through peripheral nerve and then chemically contacts muscle, and this is basically how muscle is controlled and controlled to be contracted. These cells are neurons, nerve cells, and because they're part of the voluntary motor system, they're called motor neurons. And this guy, because he lives in the upper part of the brain, is referred to as the upper motor neuron. And these guys down below, because they're down below, are called the lower motor neurons. And ALS is characterized by the degeneration or death of these cells, either upper motor neurons, lower motor neurons, or more characteristically in classical ALS, both upper and lower motor neurons. This is a somewhat more complicated slide from what I just showed you, and these upper motor neurons reside in the brain, and they're not haphazardly organized. They're actually topographically organized such that cells that run the face are located in a particular part of the frontal lobe. Cells that run the leg, for example, is in a different part of the frontal lobe. And these cells send a wire down through the brain that travels through the white matter of the brain, through the brain stem. And then depending on what these cells are connected to, some of them basically get off and connect to the lower motor neurons that they're going to control. For example, facial motor neurons here, or tongue motor neurons here, or some of them, like the leg motor neurons, will actually travel the entire length of the spinal cord and chemically contact motor neurons that reside in the lumbar enlargement of the spinal cord. So motor neuron disease, which is the proper name for this, is a neurodegenerative disorder of the voluntary system, and as I said, it's lower motor neurons, upper motor neurons, or both. And it results in various symptoms and signs, symptoms being what the patient complains about, signs being what we can see on physical examination. And it results in various symptoms and signs that are characterized upper motor neuron abnormalities, lower motor neuron abnormalities, or both. And since these cells basically are charged with running muscle, the cardinal feature of ALS, the cardinal clinical feature, symptoms and signs, is weakness. So motor neuron disease is usually used when referring to ALS, and it's often used in combination with ALS/MND But however, there are also so-called variants of ALS, MND, and motor neuron disease is also used when talking about them, and I'll discuss those in a second. One of those is progressive muscular atrophy, which is a disorder that clinically, that is on physical examination, is a lower motor neuron disorder. Progressive bulbar palsy is a disorder of the bulbar muscles, the muscles of the head and neck, clinically, and primary lateral sclerosis is a disorder that clinically appears to be an isolated upper motor neuron disorder. It turns out it's more complicated than that, as I'll describe. So there is variable association with other symptoms and signs that can occur in ALS. And in fact, I was taught that basically ALS is a motor disorder, upper motor neuron, lower motor neuron disorder, and that's it. That's wrong. We now know that ALS can have a spectrum of pathology, and therefore a spectrum potentially of symptoms and a spectrum of signs that include things that are not supposed to happen in ALS. And those include the subject of this conference, which is frontotemporal lobar degeneration or frontotemporal dementia, Parkinsonism, disorders of ocular motility, sometimes disorders of autonomic regulation like blood pressure, sweating, bladder, bowel, and sometimes sensory dysfunction. So in the ALS world, the stuff that you're not supposed to have with ALS is referred to as ALS-plus. I personally think this thing is going to go away eventually when we come to basically understand that ALS is in fact a spectrum, and that the predominant phenomena that occur in ALS are indeed upper and lower motor neuron symptoms and signs, but that depending on the distribution of the pathology, which I'll discuss in a second, you can have other phenomena occur in the disorder. So such as I said, extrapyramidal signs or Parkinsonism, if the pathology, which as Dr. Grossman mentioned to you, is nearly all the time TDP-43 pathology, you can have extrapyramidal signs, symptoms and signs like you see in Parkinsonism, like you see in PSP, because you have TDP-43 pathology in parts of the brain that can cause those symptoms and signs. You can have frontotemporal dementia because, again, you have TDP-43 pathology in parts of the brain that have cognitive consequences. You can have sensory loss, potentially, because you have TDP-43 pathology in parts of the brain that control sensation. You can have ataxia or unsteadiness because it involves the part of the brain known as the cerebellum. You can have a disturbance of ability to move your eyes on command, difficulty looking up or down, like you see in PSP, because you have pathology, TDP pathology in parts of the brain that control ocular motility. And similarly, you can have autonomic dysfunction, troubles with blood pressure, sweating, bladder, because you have TDP-43 pathology in parts of the brain that control that system. So it appears that the clinical picture that a person has on physical examination and also by symptoms is determined by the distribution and extent of TDP-43 pathology. In classical ALS, that pathology is predominantly, if not exclusively, isolated to the motor system that I just described to you, the upper motor neurons and the lower motor neurons. However, we're recognizing with increased frequency that even in those patients who appear to have classical ALS with no other abnormalities on physical examination to suggest that they have pathology anywhere else, and no other symptoms to suggest that either, that in fact TDP-43 pathology is diffuse. And I must tell you, this was a paradigm shift for the ALS world when TDP-43 was first discovered in 2006, because the mantra was, well, nothing happens in ALS other than motor disease. And as I told you, that's incorrect. And I think actually a number of my ALS colleagues are still not quite comfortable with this concept. such that, in fact, patients who have atypical ALS or ALS plus, or for example, even though on pathology they may have the same diffuse TDP-43 pathology as a person with classical ALS, they're actually excluded from clinical trials. So it's been my mission, at least one of them, to try and basically educate about this phenomenon. And this was basically the understanding of ALS when I was a resident a long time ago, and that is that there's classical ALS, which is the largest subset of these patients, and these are patients who clinically have symptoms and signs of upper and lower motor neuron disease. However, we knew that there were also people who have a disorder that is known as PMA, progressive muscular atrophy, because clinically they appear to have only lower motor neuron abnormalities, and I'll describe some of that in a minute. However, as you follow these people along with progressive muscular atrophy, as you follow them through their disease course, they can develop upper motor neuron symptoms or signs. So we changed the name from progressive muscular atrophy to lower motor neuron onset ALS. I would argue it was ALS from the jump, but that's currently what the ALS world is calling this, and in fact, PMA patients, as I said before, are excluded from clinical trials in ALS. In fact, they're not even called ALS, they're called suspected ALS, not ALS. Even though if you autopsy patients with PMA, who clinically, for their entire clinical course, have nothing to suggest upper motor neuron pathology, it's been clear for a long time, and we've also jumped into this argument, that in fact, nearly all of them have upper motor neuron pathology. They just don't manifest it clinically. So PMA is in fact ALS, although my ALS colleagues are having some issues with that. Progressive bulbar palsy is a disorder of the bulbar motor neurons, weakness of muscles of the head and neck. One could argue that this disorder doesn't actually exist, because if you thought it did, these patients would never progress to develop weakness anywhere else, right? It sounds like it should be just a disorder limited to the bulbar muscles. Well, in fact, that never happens. Progressive bulbar palsy patients always develop troubles in their limbs, always. Yet this is still one of the sort of classical variants of ALS in the ALS world. And so, I got ahead of myself here. So, but that's bulbar onset. Let me go down to PLS. I jumped one, sorry. So I'll come back to progressive bulbar palsy in a second. Primary lateral sclerosis, clinically, is a disorder of the upper motor neurons. When you examine these patients, they do not appear to have any lower motor neuron phenomena. And in fact, if you do electrical testing of muscle, which is one of the ways we detect lower motor neuron abnormalities, they're normal. However, if you follow these patients through their clinical course, all of them get lower motor neuron disease. So there's an argument to be made, and I guess I'm making it, PLS doesn't exist. In fact, it's ALS. Back to progressive bulbar palsy, none of these patients will remain isolated to bulbar musculature, and so again, progressive bulbar palsy, in my estimation, is ALS. Now, in 1999, a paper came out that basically said, are ALS patients cognitively normal? Well, a lot of us, including me, I had noticed this, but I must tell you, I didn't really recognize it as well as I probably should have. And my neuromuscular colleagues, certainly a lot of them did not as well. But it's very clear that patients can start with a cognitive syndrome of frontotemporal lobar degeneration described by Dr. Grossman, and then develop motor neuron disease, whether it be a lower motor neuron disorder, an upper motor neuron disorder, or both. And in fact, some people would say, and we're not sure this is correct, that in fact it's more likely that these patients will actually start with bulbar disease than not, although there are certainly considerable exceptions to that. And the opposite can happen. Patients can basically begin with ALS, upper and or lower motor neuron abnormalities, and develop frontotemporal executive abnormalities. And so this needs to now be included in this sort of classical Venn diagram that appeared in a book called ALS and MND by Hiroshi Matsumoto It needs now to be considered part of it. And one could argue, and I'm doing it, that in fact there should be more circles here as well, with some of those other phenomena that I described that are not supposed to happen in ALS, including ocular motility abnormalities or Parkinsonism, and some of the others. So ALS plus, to me, is ALS. And in fact, Dr. Grossman showed you a picture of this sort of heat map earlier, which is the distribution of TDP-43 pathology. And this is an example where the heat map is highest in the motor parts of the brain, and this would be typical of classical ALS. That is a person who has upper and lower motor and/or lower motor neuron phenomena. But in fact, if you look at other heat maps, and he showed you some earlier, the distribution of TDP-43 pathology can be more diffuse. And again, as I said before, the distribution and extent, it appears, will dictate the clinical symptoms of the patient. So ALS-MND is an incredibly variable disorder because it can start in any segment of the body at once. And so it can start in cranial muscles, so-called bulbar muscles. It can start in cervical muscles, muscles of the arms and hands, thoracic muscles, lumbosacral muscles. It is variable also in the speed with which it progresses. So ALS, unfortunately, because it can involve breathing and swallowing, is a lethal disease. And it can basically take someone's life in 6 months without, unfortunately, any problem. But yet, Dr. Hawking, if he really has ALS, just celebrated his 70th birthday, and he got motor neuron disease when he was 22 years old. So we think these disorders are the same, the pathology is the same. What exactly determines the speed of progression, why some people progress very quickly and why other people progress very slowly, and the vast majority are more in the middle, we really don't know. Additionally, it's variable because it begins in a segment and then it spreads. It gets worse in that segment. It can be incredibly focal. It can start with isolated tongue weakness, for example, and then spread to, say, swallowing muscles and facial muscles. But then it spreads someplace else, some other segment of the body. And this pattern of spread is variable. There's a very common pattern that we see, but the pattern is broken not all that relatively frequently. About 60 to 70% of the time, for example, if you have limb onset, and usually limb onset is asymmetric in ALS, it will basically get worse in, say, that arm, and the most likely place to get worse next is the other arm. And then the leg on the same side as the initial arm, then the opposite leg, then bulbar muscles. The same kind of pattern goes with the leg. Leg onset, one side gets worse there, usually goes to the neck, the other leg, then goes to the arm on the same side, then the opposite arm, then bulbar muscles. However, those patterns can be broken, and you can have arm onset and then bulbar symptoms. With bulbar onset, the most common place to be involved next are cervical muscles. And then the cell groups that are involved vary, and this determines the clinical picture, the upper motor neuron picture, the lower motor neuron picture, or both. And whether there's involvement of frontal and cortical motor neurons or other regions of the brain will determine the variability of the clinical picture that the patient presents with. So ALS is most commonly a limb disorder, asymmetric limb disorder, and less commonly it is a bulbar disorder, and for some reason this is more common in older women. You can have respiratory onset, in other words, weakness of the diaphragm in less than 1% of people. You can have thoracic or axial onset in less than 1% of people. Exactly how many present with this is not entirely clear, but we know, as Dr. Grossman told you, that about 12%, 10% of patients with ALS have cognitive dysfunction. How many of those actually begin with cognitive dysfunction and then get motor system disease is not entirely determined. And so the variability of the location of the cells degenerating, the kind of cells degenerating, whether they be upper motor neurons or lower motor neurons, determine the symptoms. And so with axial symptoms, in other words, trunk symptoms or hold your head up symptoms, people can have trouble holding their head up. And we use things like collars and cervical collars to help with that. Or they can have truncal instability or difficulty maintaining an erect posture and fall forward and bent at the waist. They can have increase in the curvature of the low back if they have low back muscle weakness. Their belly can become more protuberant because the abdominal wall muscles become weak. With diaphragm or intercostal muscle weakness, they can get short of breath, dyspnea, or they can have trouble lying flat. They get short of breath lying flat, orthopnea. They develop troubles breathing at night because our breathing is most vulnerable when we sleep, and if you have diaphragmatic weakness, you can develop so-called sleep disordered breathing, which causes you to be sleepy in the daytime, so they have excessive daytime sleepiness. They can have headaches, much like people with sleep apnea, for example. They can have confusion, hallucinations because of hypoxia related to sleep disordered breathing. With bulbar symptoms, they can be hoarse, or some change in the character of their speech, or they can have slurred speech, dysarthria. They can progress to develop anarthria. They can't speak at all. And so we, at the center, we have a significant program basically helping people with alternative slash augmentative communication skills. They can develop troubles with swallowing, and this could be oral, because you have to, chew your food and then move it around in your mouth and then propel it back. And tongue weakness can cause troubles with oral part of the swallowing phase, or it can be pharyngeal, the swallowing muscles of your throat. And so they can cough and choke and develop malnutrition and dehydration because they can't consume enough calories, they can't consume enough liquid to maintain those vital functions. And this is one of the life-threatening issues with ALS. They can develop chewing trouble because we process our saliva and mucus by swallowing, and if the swallowing muscles are affected, people can begin to drool. They have sialorrhea, and they can have trouble processing pharyngeal secretions. They feel like they have postnasal drip all the time in the back of their throat. So a lot of our treatments are directed at managing secretions, and Rachel told you earlier about the use of Botox, which we utilize as well. There's also an odd set of symptoms that occur known as the pseudobulbar affect syndrome, where people have a lower threshold to cry or a lower threshold to laugh, or both. And so they cry over stuff they wouldn't have cried over before, and they can't stop. Or they laugh over stuff that they wouldn't have laughed at before, and they cannot stop. This can be socially difficult because if you're having an argument with someone and you start to laugh, that can get you into trouble. People, no one likes to see people crying, but the interesting thing about this is mood incongruent, meaning this person who's crying in front of you, you ask them if they're horribly sad, and the answer is no, I'm not sad. So it's really their affect is abnormal, what you see, but their mood is not. They're not crying because they're terribly sad. It's basically the release of circuits in the brainstem that basically control crying and laughing. And similarly, this person who's laughing, you might think they're really happy, but they're not. Same idea. Another thing that comes with this is forced yawning, big, giant yawns, even though they're not sleepy. Limb weakness is most common and causes various kinds of disability, and ALS can progress to quadriplegia, complete weakness of the arms or the hands, and so you're completely potentially dependent on other people for activities of daily living, bathing, dressing, toileting, etc. But on the other hand, the weakness may not be so profound. It may be difficult, but not so profound, and not leading to complete paralysis. With lower extremity symptoms, people have trouble standing, walking, and may eventually lose the ability to walk. They fall. Now, Dr. Rachel was talking about this impulsivity problem. Imagine coupling a disorder that causes such motor system disease and troubles with balance and walking, and now coupling it with impulse control problems that can come with frontotemporal lobar degeneration. It's a prescription for disaster. It's a prescription for falling and breaking bones and getting head injuries, and these poor people can't stop it because they're impulsive. Or imagine coupling swallowing trouble with impulsivity. You're coughing and choking even on small amounts of food, and meanwhile you're stuffing all this stuff in your mouth because you have an impulse control issue, a prescription for disaster. Cramps are common, muscular twitching is common. And then the signs, what we see on exam, upper motor neuron signs, lower motor neuron signs. Upper motor neuron signs are weakness, but not so weak. Power is pretty good, but it's more of a discoordination, a slowness, often accompanied by very increased reflexes when the doctor whacks you with a hammer. Pathological reflexes like the so-called upgoing toe or Babinski sign. Loss of cutaneous reflexes. The limbs are stiff. And in a way that's different from what you see in extrapyramidal disease or Parkinson's disease. Although sometimes, I've been in the room where 3 or 4 neurologists are arguing about whether it's spasticity or rigidity. It has a different feel most of the time, but sometimes we have trouble telling them apart. And then the pseudobulbar affect syndrome I just described is an upper motor neuron phenomenon as well. Lower motor neuron abnormalities include muscular atrophy, profound loss of the size of muscles, often accompanied by twitching. And if this is the only thing going on, the reflexes become reduced or absent, and the limbs become floppy because the tone is reduced. They're not spastic, they're reduced. In classical ALS, you see a combination of these things in various parts of the body, whereas in progressive muscular atrophy, you see this. And in primary lateral sclerosis, you see that. Again, clinically, but as I said before, pathologically, it's a different story. We actually see pathologic abnormalities of the upper motor neuron and lower motor neuron in all the disorders I just mentioned. So the diagnosis of ALS is basically clinical. There is no test. We too have been interested in looking at finding a biomarker in spinal fluid to see if we can tell if somebody has ALS or not, and that doesn't yet exist. But basically the history needs to be one of progressive painless weakness without sensory loss that begins usually locally in one segment of the body, often even in one muscle sometimes, and then spreads in that segment and then spreads to another segment. And the lack of so-called exclusionary symptoms that I've mentioned before, although perhaps not so exclusionary when you take the whole syndrome, whole spectrum in mind. The examination needs to detect the presence of upper motor neuron, lower motor neuron, or upper and lower motor neuron signs, what I just showed you before, and lack of exclusionary criteria like sensory loss and stuff like that. And then the laboratory electrodiagnostic testing, that's testing of nerve and muscle electrically, imaging needs to basically not point in a different direction. It needs to basically exclude things that mimic the disease, mimic ALS. And then once all of these 3 pillars are basically satisfied, that's how you make the diagnosis of ALS MND. And ALS, the classical ALS, is the commonest form of motor neuron disease. It's a rare disease as well. It's about 1 to 3 per 100,000 population. Below the age of 65, it's 2 to 1 men. And above the age of 65, it's about 1.4 to 1 men. The peak incidence is in the 5th to the 7th decade, but I unfortunately made the diagnosis of ALS in a 19-year-old woman 2 weeks ago, and we unfortunately see people in their 90s with ALS. So there's a considerable spectrum, although there's this peak in the decades here. And unfortunately, ALS is lethal because it causes troubles with swallowing. And most commonly, patients die of respiratory failure, progressive weakness of the diaphragm. And from the time of diagnosis, the average length of life is about 4 years. But as I told you before, ALS can be rapidly progressive, and a person could potentially die in less than 6 months, whereas a person can actually live for 10 or more years, and we don't know why this is the case. So there's a greater than 30-fold difference between the fastest and the slowest forms of the disease. Most of ALS is sporadic, 90% of it, and nearly all of those people have TDP-43 pathology. Occasionally we're surprised, but most of the time it is TDP-43 pathology, and as I told you, it's usually centered in the motor system, but it can be more diffuse than that. 10% of ALS is familial, or so-called FALS, and it further cements the relationship between FTLD and ALS because some of these genes cause both. So a mutation in the TDP-43 gene, the gene that makes the protein, that codes for the protein TDP-43, people with this mutation get ALS and they can get frontotemporal dementia. The FUS gene, the fused and sarcoma gene, also is a gene that causes both ALS and frontotemporal lobar degeneration. The chromosome 9 gene that was just discovered a couple weeks ago also causes ALS and frontotemporal lobar degeneration. And the valsalin-containing protein gene, VCP, is a gene that causes a muscle disease called IBM, but it's now clear it causes frontotemporal dementia and it also causes ALS. So in sporadic ALS, there's clearly an association with frontotemporal lobar degeneration, as I mentioned, but now we know there's also a genetic link in familial ALS as well. And with that, I thank you for listening.
So you've now heard a great deal about the spectrum of clinical manifestations of conditions related to FTD. What we'd like to do now is take a little bit of a break for about 15 minutes or so. Then we'll have you come back and we'll talk a little bit more detail about the genetics and about some new treatments that are on the horizon for FTD. So thank you.